Hello, this is Dr. Mark Rosen, and today we're going to be talking about ultrasonography and how it relates to deep vein thrombosis, in particular in the ICU or in the emergency department. So a first question that we might ask is, why do we care about deep vein thrombosis ultrasounds? Some facts are worthy of remembering. Approximately half of proximal vein thromboses cause pulmonary emboli. And the way that I look at it is, unless a person is already being treated with anticoagulants or already has an IVC filter in place, there's no such thing as a test to rule out pulmonary embolism in a patient really suspected of it unless the test is ordered as a stat. Why is this? Because about 25% of patients with PEs are destined to die, and 90% of those who will die do so in the first 1 to 2 hours of the pulmonary embolism. So obviously time is of the essence. Now ultrasonography is about 95% sensitive and 98% specific for patients with symptoms of DVT. So I'd like to go over a study, the results of short-term training of naive physicians in focused general ultrasonography in the ICU. The purpose of this study, which was published in Intensive Care Medicine in 2009, was to evaluate the ICU physicians who had very limited training and essentially no knowledge of ultrasonography and how they would perform basic general ultrasonography after a short course. The course consisted of 8.5 hours of training with a 2.5-hour didactic course and 3 hands-on sessions of 2 hours apiece, total of the 8.5 hours. And the radiologist on duty performed the same examination and was blinded to the results. And then questions were asked about the presence of pleural fluid, intra-abdominal effusions, cholecystitis, duct dilatation, chronic renal disease, obstructive uropathy, and DVTs. The bottom line of the study was that the physicians who were naive to ultrasonography before this 8.5-hour didactic performed extremely well, comparable to the radiologist for these limited focused sonograms. Now this is an important distinction. People who are learning to do limited focused ultrasonography should not be confused with radiologists who perform in-depth complete exams. We're looking to ask a question, solve that question, and have a treatment plan that's effective. Let's look at another study. The reduction in deep vein thrombosis incidence in the intensive care unit after a clinical education program. Now, the purpose of this study was to look at the effect of an educational program on the incidence of deep vein thrombosis. My experience is that whenever you teach people something, they tend to perform better. So it was no surprise that after a 1-year educational program, the incidence of deep vein thrombosis in the ICU went down. Many people had been somewhat lax in prophylaxis and so forth with their patients, and an educational program kind of made them do what should be the standard of care. So the incidence of DVT decreased dramatically from 11.9% to 4.5% with this program in effect. But I look at this something and I glean a different message, and that's that even with an educational program where everybody is getting prophylaxed, 4.5% of ICU patients still had deep vein thrombosis. It's a huge number. Maybe 1 in 25 patients. And interesting, the duration of mechanical ventilation, use of vasopressors, and neuromuscular blockade increased the risk, with neuromuscular blockade as the strongest independent predictor for DVT incidence. Once again, one more reason to try to avoid using neuromuscular blockade if possible. So sometimes the diagnosis, as in this situation, is seemingly obvious, where you have a red swollen leg. And sometimes over here, after a plane flight where the leg hurts just a little bit, it can be a bit more subtle. But in virtually every circumstance, we need confirmatory evidence, and ultrasonography is that confirmatory evidence. A linear probe, as most of you know, is best for superficial structures. It's got a high-frequency transducer, so it's very good for visualizing the superficial structures with excellent resolution. It can't penetrate very deeply, but even though we call the entity we're discussing deep vein thromboses, the deep veins are actually fairly superficial. So a little bit of anatomy, very basic. Just below the inguinal ligament are the paired superficial and deep femoral arteries and veins. And the femoral veins course next to the arteries. Now sometimes it can be difficult to remember in the heat of a moment when somebody's hypotensive, or when you're just looking at an image on a screen as to which is the femoral vein and which is the femoral artery. First, remember that the artery and vein do course somewhat medially, and when you examine them, what I recommend doing is following the femoral vein approximately every centimeter for 5 to 6 centimeters to rule out a femoral vein DVT, and we'll talk about how to do this in a minute. The probe slides down transversely across the femoral vessels, and every centimeter is compressed. A linear probe is placed in a transverse position over the blood vessels, and then with compression, the artery may compress a bit, but the vein winks out. If there's no obstruction, it disappears. The artery becomes somewhat thicker at the edges and somewhat more pulsatile, but it will go up and down on the vein, just winking. Now, before compression, in the top image, you can see the common femoral artery, the superficial vein, and the common femoral vein. In the bottom image, after compression, the common femoral vein winks out. There is no clot. So here's what I was talking about before. How to tell where the femoral vein is in location to the femoral artery. A lot of us have learned the mnemonic NAVAL. Nerve, artery, vein, empty space, and ligament. But you have to remember, you must spell navel going towards the navel. So on one side it's navel, and on the opposite side it'll end up being Levan if you don't spell it going towards the navel. So at UCI, it's become popular to remember something, and I apologize for the use of anatomy, which may be uncomfortable on a tape, but it's easy to remember. Venus is near the penis, and at one of the conferences, a female doctor complained, so then one of the doctors came up with V for vein and V for vagina. Sorry about the anatomical components here, but I assume we are all doctors. So we move on. Now over here, note how the femoral vein over here starts off medially and then starts to move inferiorly below. It winks out with compression, and there's no thrombosis. And by the way, this up here, this is the typical appearance of a lymph node. But this is the important structure, winking out. Over here, we have a femoral vein that does not wink out. So there's a clot inside this vein. And you'll notice the vein is also somewhat enlarged because of obstruction in the vein. The artery over here gets a little bit thicker as we compress it. And you can see a little bit of pulsations as well. The common femoral vein here does not wink out. So looking at this end here, we see the artery. It's really overly compressed, almost disappearing. Someone's applying really too much force. You can see it pulsating, the walls of the artery thick over here. But the vein over here actually has a clot visible right where the arrow is. And we'll wait and take a look at that one more time. Right there is the clot. And it's certainly not winking out. Looking at the popliteal fossa, it's important to remember that the vein is superficial to the artery. So remember, when you're looking at an image, the structure you're looking for is the popliteal vein. So pop on top. The popliteal vein is on top. And we need to examine 4 to 5 centimeters in the popliteal fossa to rule out a deep vein thrombosis of the popliteal vein. So there are different ways to examine patients. If the patient is able to sit, as in the emergency room, you can examine the patient sitting, as in this image. But sometimes in the ICU or in the emergency department where a patient cannot sit up, they're too sick or they're on ventilators, then I like to examine them in the supine position, and I just take their heel and bend it up a bit, and I can put my probe underneath into the popliteal fossa, or you can frog out their legs and have the hips abducted so it opens up the popliteal fossa a little bit, the hip a little bit, so you can get to the popliteal fossa and they're both opened up. Now in this image, the popliteal vein winks out over here, so there's no DVT. And again, take note that this one's on top, pop on top. Over here, pop on top again. This is pop on top. And it doesn't compress, and actually you can even see over here, I've frozen the image so you can see the popliteal DVT here. In this case, Doppler is used to light up an area with blood flow. And again, pop on top. First clue, even before you compress, is the size of the vein. It's extraordinarily large compared to the artery. And then, of course, with Doppler flow, we can see that the artery is lighting up, the vein is not. We can even see over here the clot. And interestingly, in addition to the vein not lighting up, in addition to the vein not being able to be compressed, in addition to the vein not being of normal size and caliper, what's going on with the color flow in the artery? So just a moment to talk about the flow. Initially, a lot of people think blue is vein and red is artery, and that's not so. If we look over here at the legend or the dictionary, the top is red, the bottom is blue. And red means that the blood is coming towards us. Blue means the blood is going away from us. So some people remember the mnemonic BART, as in the transportation system in San Francisco, blue away, red towards. I like to remember that red is coming towards us, like give me all the love. And blue is going away. I don't need this icy cold relationship. Sorry, but that's how I remember it. Moving along, why is there over here blue and yellow and a little bit of green flashing every now and then, in addition to the red? Look at the dictionary or the legend here. So if red is towards, as you go up higher and reach the yellow, that's giving you true velocity. Distance as well, speed as well as direction. So yellow means it's going very fast toward us. Green means going very fast away from us. Why do we have towards, away, fast, slow? Part of it's because we're compressing, but even when I'm not compressing at all, there's tremendous turbulence, and that's from the clot. So you can learn a lot from the Doppler. Now in this case, this is a different type of Doppler. This yellow, if you look at the legend, only has the yellow, and it's only in one direction. This is power Doppler. This is just showing flow at all. So you'll see the regular beating down here, that's the artery, pop on top, that's the vein, and what you see is it's actually outlining where the flow is, and over here in this enlarged vein, it's outlining where the clot is. So a positive DVT scan of the popliteal vein. Now a question. You have four choices. Number one, A is the common femoral vein and artery, and B shows a DVT. Number two, A is the common femoral vein and artery, and B shows no DVT. And 3 and 4, popliteal artery on top and no DVT, popliteal vein on top, and B shows no DVT. I'll give you a minute to take a look at it, and if you're listening to a recording, you can place this on pause. And now I'll give you the answer. A is the popliteal vein on top, and B shows no DVT. Now the reason why I talk about this on this question is not to make the person who's viewing this right now struggle with a plain image and say, I'm not exactly sure what's happening here. Because sometimes it's hard without any knowledge to know exactly what you're looking at on one still image. But it illustrates one point. In my experience, if one looks at the popliteal fossa and you only see one structure, the most common reason is because the person who's performing the test is pressing ever so slightly and actually compressing the vein. It is incredibly superficial. So the vein is on top, and what's happened over here is there's some compression, and that's the artery that's moved farther up more superficially, and the vein is completely collapsed. Now there are two different types of compression. There's the two-point compression, which is commonly done for a limited exam, problem-focused exam, and there's the traditional technique, which is more commonly done by the radiology department. For the two-point compression, the scan is performed at the insertion of the great saphenous vein and the common femoral vein distally, and it's performed at the proximal popliteal vein to the bifurcation. The traditional technique, you follow the vein throughout its course and also do other techniques such as flow, augmentation where you squeeze the calves to see increase in flow, and so forth. We'll come back to that. But first we're going to see, can physicians who are non-radiologists and not ultrasonographic techs be accurate and fast? So this was a study from the Academy of Emergency Medicine in 2000 on low extremity Dopplers for DVTs. Can emergency physicians be accurate and fast? In the study, with 112 patients enrolled, there were 34 DVTs. There was agreement in 98% of the cases between the radiologist and emergency medicine physicians. There was one combative patient that the emergency department physicians called positive and the radiologist called negative. And the flip side of that is there was one that the emergency department called positive and the patient called this scan negative. But the venogram turned out revealing that it to be positive. So tremendous agreement, 98%. And to me, quite interesting is the median time for the emergency medicine physicians to perform the test was a little bit under 3.5 minutes. So the conclusion was that emergency physicians could perform low extremity Doppler ultrasound exams quickly and accurately. And my corollary is therefore that I think other physicians, such as intensivists with similar ultrasound training, which in this case was quite minimal, would be expected to have similar results. Other studies have revealed the same results. There was another study in Chest 2000 which looked at deep vein thrombosis caused by femoral vein catheters in the critically ill adult patients. And the objective was to determine the frequency of and potential risk factors for catheter-related DVTs in critically ill adult patients. 124 patients were evaluated. 14 patients developed iliofemoral DVTs, only 2 of which were clinically obvious. Interestingly, almost 10% of the patients had DVTs on the side of the femoral catheters, and they were not clinically obvious. There was no relationship to the number of assertion attempts, arterial puncture, hematoma, or duration of catheter. Somewhat surprising to me. The bottom line, however, was that the use of femoral lines increases the risk of iliofemoral DVTs and may occur as soon as 1 day after cannulation, and is usually asymptomatic. So my rule of really has been this, and studies like this just reinforced it. I try to avoid femoral vein catheters if possible because of the risk of DVTs. But if I need one in an emergency, that's fine. But then as soon as I can, I try to get a different line. Even 1 day out, 10% almost will have deep vein thromboses start to occur. Ultimately, it'll be 10%, not at 1 day out, but it will start at 1 day out. But more importantly, or equally important, I should say, is that they're usually asymptomatic. Another study looked at compression ultrasonography of the leg veins in patients with clinically suspected pulmonary embolism. Is the extensive assessment of compressibility useful as compared to the two-point compression? So this was one of many, many studies that have been done. This one looked particularly at stratifying this compared with pulmonary emboli patients as compared to DVT patients. Bottom line is all the studies basically show the same thing. For pulmonary embolism, there were 479 patients with a two-point exam. 461 then underwent extensive leg compression sonography. And the radiologist and the physicians doing it were blinded. And you had a 32% sensitivity and 23%, and you had a 23% sensitivity and a 98% specificity in the two-point exam compared to a 25% and 97% respectively. So for pulmonary embolism, the sensitivity and specificity were virtually identical, and this has been borne out in many studies in looking at DVTs as well, not just as it relates to pulmonary embolism. So bottom line on this is compression ultrasound has a limited sensitivity for the detection of thrombus in patients with pulmonary embolism. We sort of already knew that. But a more extensive examination of compressibility of the leg veins has no additional value as compared to two-point assessment. An important fact to remember, especially when used in conjunction with the prior study, that residents who were essentially naive to doing this exam were able to perform both legs by ultrasound in less than 3.5 minutes. So after this course, where you go through a lot of these lectures, you have hands-on sessions, you'll become familiar with performing the DVT ultrasounds, but then practice is super important so it'll become accomplished. And there may be some times where you need to call for help. Start off with the easier patients, certainly, and then there are some cases where you definitely might need assistance. Elephantiasis.